Thank you very much, Dr. Mehta. Can I have the next slide? So this is the case that we're going to now discuss. Case of productive cough, and this is an elderly gentleman, a 63-year-old male. He's retired. He's come to us with productive cough, which is green-colored sputum. He has fever and shortness of breath and fatigue for 2 days. So the history tells us that we have an elderly gentleman who's having fever, shortness of breath, fatigue, and cough with green-colored sputum. He's also a known patient of COPD for the last 6 years and has been on bronchodilators as part of his treatment. And he's had a similar attack during winter 2 years back. He's also has hypertension for 2 years and is on calcium channel blocker. So he's been an ex-smoker, so his COPD is smoking related. He's a non-alcoholic and he has moderate obstructive effect. If you look at his FEV1, spirometry, which was done 6 months ago, suggests that he had a predictable FEV1 was 52% of predicted. So this history tells us that we have a person with COPD who has moderate COPD related to smoking, has had an exacerbation 2 years ago for which he was treated, and now has come with a short history of fever, productive cough, progressive breathlessness and fatigue. May we have the next slide, please? So when you examine this patient, he is normal, his blood pressure is alright 140/90, but his saturation is dipped, it's 90% at room air. So he has a borderline oxygen saturation, he's defibrillated, his heart rate is on the higher side, 100 beats per minute, and he is tachypneic with a respiratory rate of 30 per minute. On auscultation, the reduced breath sound, which can happen in a patient with COPD because of emphysema and decreased air entry. There are crackles and wheeze which is heard, so he has both crepitations and wheeze, which suggests that there is both airway and parenchymal involvement. His abdominal examination is essentially normal, and he is alert, he is oriented. There is nothing to suggest that he may have CO2 narcosis. I assume that there are no flapping tremors also, so possibly he does not have CO2 retention. So a chest X-ray was advised. Can you go to the next slide, please? So basically, based on this, what will be the possible diagnosis? Now we have a multiple possibility when we have a person with COPD who comes with worsening of breathlessness. One, of course, is an infective exacerbation, an acute exacerbation of COPD, exacerbation occurring because of an underlying lower respiratory tract infection. COPD patients can have heart failure. They may have, because of smoking, coronary artery disease, so they could have left heart failure. They could have pulmonary arterial hypertension, which could lead to right heart failure, and that can also lead to worsening of disease. He could have a simple pneumonia without an exacerbation of COPD. And if you were to look at other possibilities in this patient, which seem less likely, one would also consider things like pulmonary embolism or a pneumothorax, which sometimes happens if you have emphysema or you have bullae. Next slide, please. So when you approach such a patient, then there are two things that we need to do. Whenever we have a COPD patient suspected exacerbation, one is confirm that this is an acute exacerbation of COPD rather than other causes like heart failure, pneumonia, pulmonary embolism, pneumothorax. And this is easy to do clinically. You try and look for the heart sound, you will see whether the JVP is raised, whether he has features of course crepitations. Pneumonia is something that we can diagnose. And if you are suspecting pulmonary embolism, one would definitely get an echocardiography done. But if you consider that he has exacerbation of COPD, then the next step is to look at what is the severity. Is it mild, is it moderate or severe? And there are various guidelines which have been mentioned based on clinical parameters. If your dyspnea score looking at the visual Randolph scale is less than 5, so he is not that dyspneic. His respiratory rate is less than 24 and heart rate is less than 95 breaths per minute. And this is a mild COPD exacerbation. The resting saturation, if you can take it, should be more than 92% while the patient is on room air, and or change less than 3% when the patient is on oxygen. And if you have a CRP level, ideally it should be less than 10 milligrams per liter. In a moderate exacerbation, the VAS score is more than 5, patient is tachypneic, has tachycardia, and CRP level is also high. And again, if the saturation is there, it is usually less than 92. And in severe cases, parameters are same, but the AV sheet shows features of hypercapnia. So if you were to look at our patient, he tends to fit into the moderate category. He is having higher heart rate, he is tachypneic, and he has a saturation which is less than 90%. And like I've said, that we have tried to rule out other conditions which could lead to exacerbation or worsening of in a person. We need to do some testing. We can do viral testing. There are rapid PCR tests now available for viruses because exacerbations in COPD can be viral etiology. A sputum examination will help us, but we don't give us a report immediately. And other tests will be done like antigen blood gases, and like we already mentioned. Next slide, please. So this is the chest X-ray of the patient, and as you can see, there is flattening of the dome of the diaphragm. There is some degree of hyperinflation. The hyla are looking full. There are some degree of diffuse interstitial shadows. There is a little bit of a non-homogeneous opacity seen on the right base, but otherwise, overall, the X-ray doesn't show a big consolidation per se. Now, the most common bacterial cause of acute exacerbation of COPD is sometimes we used to talk about the big three, that is Haemophilus influenza, Moraxella catarrhalis, and at times Staphylococcus pneumoniae. In tertiary care hospital, one is also seeing Pseudomonas being reported more and more, but in the community setting, that tends to be a little bit less. So this patient has diagnosed with acute exacerbation of COPD, like I said, of a moderate degree of severity, and this seems to be because of his features due to infection. Next slide, please. So the first question that comes from when we have a person with acute exacerbation is, should I give antibiotics to his kids, or should I just treat him with nebulized bronchodilators, maybe a short course of steroids, because this may be a non-effective exacerbation of COPD. So like we did for community-acquired pneumonia, how do you decide whether this exacerbation is viral or whether this is infective, bacterial infection, or this is a non-infective exacerbation? Next slide, please.
Such a big speaker.
So if you have a person who has productive cough and breathlessness, then the effective exacerbation of COPD, there are certain factors that you would consider, and there are various guidelines which have come out which try and help you in trying to really look at this. We have the National Treatment Guidelines of 2025, the NICE recommendation also. The National Treatment Guidelines acknowledges that most of the infections may be caused by viral respiratory infection, and antibiotics should be considered if there is increased shortness of breath, increased sputum volume, and increased sputum purulence. So these three parameters make you decide whether this is infective and whether it's a bacterial infection or not. The NICE guidelines recommend that one should consider antibiotics looking at the severity of symptoms, and the first thing is the sputum. So you must ask your patient what is the color of sputum, has it increased in volume from what he was seeing in the past, and then take a decision whether hospitalization is needed. If there is a previous history of exacerbation and risk of complications, one should have a low threshold and start the patient on antibiotics. If there is previous sputum culture which has shown infection and the patient has been on repeated antibiotics, then you should take a call on what antibiotics to give, and the risk of antimicrobial resistance needs to be considered. If you look at the latest board guidelines, they say that antibiotics should be given to patients who have these three cardinal symptoms, and this is increase in dyspnea, sputum volume, and sputum purulence, or have two of the cardinal symptoms. If increased purulence is one of them, or require mechanical ventilation. So obviously, if the patient requires non-invasive or invasive mechanical ventilation, if he requires BiPAP to maintain his saturation and has CO2 retention, one would consider giving antibiotics. Or if there is increase in volume of sputum, or the sputum becomes yellowish or yellowish green, then this is suggestive of a bacterial infection and antibiotics should be given. Next slide, please. So now if we decide that we need to give antibiotics, the second question comes, what should be the first line antibiotics in this case? This is a patient who's come to us with a community-acquired exacerbation of COPD. He has not taken antibiotics. He had an exacerbation 2 years ago. So we have multiple choices. Should we give an amoxicillin clavulanic acid combination? Should we give a quinolone in the form of moxifloxacin, which has a broad cover for typical and atypical? Should we give a macrolide like clarithromycin? Or we should look at a combination of cefuroxime with clavulanic acid. Next slide, please. Now, if you look at the data and you start looking at it, the option that we had were basically, one is moxifloxacin. In a country like India, we do not really recommend moxifloxacin. All the Indian guidelines say that quinolone should be given because there is enough data that suggests that if there is underlying tuberculosis, then fluoroquinolones can mask the TB and it can delay the diagnosis almost for 4 to 6 weeks. And obviously, it can promote drug resistance because you're giving monotherapy. A macrolide like clarithromycin as a standalone treatment is usually not given now because there are now data showing that there is resistance occurring as far as macrolides are concerned. Pneumococcal resistance is rising in up to the tune of 25 to 30% according to the ICMR surveillance data. And the combination of cefuroxime and clavulanic acid is an irrational fixed-dose combination and offers no additional side benefit and therefore is not really recommended. If you go by the guidelines say that the first line treatment should be amoxicillin clavulanic acid 1 gram twice a day. If you could also give cefuroxime or cefuroxime, but remember the first antibiotic recommended is amoxicillin acid combination. If the patient is sick and you want to give injectables, you could still give amoxicillin clavulanic acid in the injectable form, but you could also give ceftriaxone 2 gram IV once a day as an alternate. Again, like we discussed previously, the duration of therapy is usually 5 days, and one should look for the symptoms of exacerbation, which is fever, sputum purulence, worsening of bronchospasm, and worsening of oxygenation, and these should be monitored closely in these patients because these patients have already a compromised lung. Next slide, please. Now the issue is, what is the efficacy of amoxicillin clavulanic acid? Because if you go by the Western guidelines, many of the Western guidelines still look at fluoroquinolones for the simple reason that they are simpler to give and once a day therapy. But like I mentioned, in our country, we don't recommend using fluoroquinolones. But if you look at the data, it suggests that amoxicillin clavulanic acid is as effective as moxifloxacin in the treatment of outpatient treatment of acute exacerbation of COPD. And this study shows that both therapies were well tolerated and had an equal efficacy, with failure rates being pretty similar. So in our setup, where we are not giving a fluoroquinolone, I think the treatment of choice would be amoxicillin clavulanic acid. Next slide, please. So in this patient, the final diagnosis is an acute exacerbation of COPD before infection. The severity is moderate. The patient could be treated on outpatient basis with a combination of amoxicillin clavulanic acid 1 gram twice daily for 5 days. And the question always comes, is 5 days sufficient for most infected acute exacerbation of COPD? By and large, the data suggests that 5 days is good enough. You have to see the patient's response and whether the patient has had underlying comorbidities which may delay the response to some extent. But in most cases, 5 days is usually enough as far as treatment is concerned. Next slide, please.
Yeah, we will go with the case, but before we go, sir, very important message which you have conveyed was that acute exacerbations of COPD may not always be infective, and there are specific points which we need to keep it in mind. And infective exacerbations are always not necessarily bacterial in origin. So, sir has given very beautifully the guidelines or recommendations depending on which should be doing it, and the duration, which is very clear cut, that within 5 days most of these respond very well. Okay, now let's look at another case scenario with tubular nasal discharge, and I will invite Dr. Ilambarthi to present this case. Dr. Ilambarthi, please.
Thank you, Dr. Ketan and Dr. Valeria. So thank you for the context setting and also nice presentation by both the senior doctors. So now we can go for the third case. So look at the case scenario with the purulent nasal discharge. So a case of greenish nasal discharge with the mandibular pain. If you see the case presentation, 35-year-old man, school teacher by profession, purulent greenish colored nasal discharge he has got. His main complaint is the nasal discharge, and he has come with the high-grade fever, and he has got facial pain, maxilla and mandible, and this is for more than 10 days, and it is a known case of allergic rhinitis, and he is on fluticasone. and he is a non-smoker, he smokes about 1 packet per day. He is a social drinker. He is taking painkiller for pain from local pharmacy, and he is a non-diabetic. He gives history of similar complaint, no history of similar complaint or antibiotic intake for the past 3 months. So the patient visited a local physician who gave him azithromycin 500 milligrams once daily for 5 days. But after 3 days, he started feeling unwell and the symptoms he got aggravated. Next slide, please. So coming to the clinical examination, his BP pulse almost normal and his fever is 103 degree Fahrenheit. On systemic examination, chest examination is normal, abdomen is soft, CM is also normal. So we always do diagnostic nasal endoscopy when there is a nasal purulent discharge and also facial pain. And the nasal endoscopic examination in this patient showed purulent nasal discharge in the nasal cavity and also in the middle meatus. Patient has got a mucosal congestion and edema, and also bilateral inferior tubular hypertension was noted. And the purulent nasal discharge was known as going into the nasal valves. What we call it as a post nasal fit also is seen in this patient. Next slide, please. So, what should be the right diagnosis in this case? So, a case of venous nasal discharge with fever more than 103 degree, and the patient has got a patient pain. So, all these things put together. Then, next slide, please. So, we have to diagnose this as an acute bacterial rhinosinusitis, and since the patient has got a complicated symptom, it comes under the complicated sinusitis as per the NTG guidelines. So, patient with the history of acute onset of high fever with facial pain and purulent nasal discharge with mandibular and maxillary pain. So, all these things have to be diagnosed as acute bacterial rhinosinusitis. If you see the diagnostic criteria, the signs and symptoms are more than 10 days without improvement. Fever is also more than 39 degrees centigrade and purulent nasal discharge, and the facial pain is more than 3 days from the beginning. And the most important thing in acute bacterial sinusitis is double thickening. Initial improvement in 3 days, again patient symptoms are worsened. That is what we call double thickening. So after the initial improvement, so the final diagnosis in this patient is bacterial rhinosinusitis.
टाइम लग जाएगा जाने में।
So the patient visited a local physician who gave him azithromycin 500 milligram once daily for 5 days, but 3 days later, patient started feeling unwell and symptoms aggravated. So what early red flags is to prompt escalation or referral in this case to an ANT physician. And what do we think that the antibiotic selection in this case was appropriate, and what would be the rational first line antibiotic? Next slide, please. So if you see the NTG guidelines, the first line drug for acute bacterial rhinosinusitis, especially in complicated sinusitis, we can go for either amoxicillin 1000 milligram or amoxicillin clavulanic acid 1.2 gram, or we can go for amoxicillin clavulanic acid 1 gram twice daily per word. Alternate drugs that are prescribed in the acute bacterial rhinosinusitis are cetirizine 400 milligram daily for 7 days, or doxycycline 100 milligram twice daily for about 5 to 10 days. Next slide, please. So the amoxicillin clavulanic acid has the clinical and bacteriological response rates comparable to those of clarithromycin acute bacterial rhinosinusitis. If you see the diagram, the amoxicillin clavulanic acid, the clinical response is 97% comparable to clarithromycin. The bacteriological response is also about 93% compared to the clarithromycin. So both antibiotics are well tolerated, but if you see the flow chart also, the amoxicillin clavulanic acid and clarithromycin are both are comparable. Next slide. So the final diagnosis is acute bacterial rhinosinusitis. And the antibiotic prescribed is amoxicillin clavulanic acid, 1 gram twice daily for 7 days. So the ABRS, the treatment duration is about 7 days. Next slide. So what key clinical factors guide your decision to prescribe amoxicillin clavulanic acid 1 gram twice daily for a patient of acute bacterial rhinosinusitis? Next slide. So if you see the spectrum of coverage, the broad spectrum coverage, because the common causative organisms of bacterial rhinosinusitis are streptococcal pneumoniae and the Haemophilus influenzae and the Moraxella catarrhalis. And if you see the streptococcal pneumoniae species, it can be a penicillin susceptible streptococcal pneumoniae or penicillin intermediate and penicillin resistant streptococcal pneumoniae. And you require higher dose of amoxicillin in penicillin resistant streptococcal pneumonia, that is PRSP. You require definitely a high dose of amoxicillin to treat the PRSP strains. Likewise, it is effective against staphylococcal aureus and also streptococcal pyogenes, H. influenzae. And if you see the chart, almost all the causative organisms causing acute bacterial rhinosinusitis, and the coverage is AMC covers almost all the organisms. Next slide. So if you see this chart, clinical susceptibility data of that is amoxicillin clavulanic acid against the key respiratory pathogens. The 3 pathogens, as I told you, streptococcal pneumoniae, H. influenzae and the Moraxella catarrhalis. And if you see the coverage for the streptococcal pneumoniae is about 91.8%. And for the H. influenzae is also almost 97%. And also for Moraxella catarrhalis is about 98.4%. So when you compare it with the macrolides like clarithromycin or quinolones, you can see the decrease in the susceptibility with the other antibiotics.